del foro 32º del recinto de Ciencias Médicas de la Universidad de Puerto Rico. En esta ocasión vamos a dejarles saber primero que la Escuela de Enfermería y la Escuela de Odontología han desarrollado una una colaboración para desarrollar su infraestructura y colaborar en proyectos y en investigadores. Y esta es la primera actividad en realidad que llevamos en conjunto, ¿verdad?, con la Escuela de Enfermería, y estamos muy contentos y tenemos unas buenas noticias que darle al final. Y agradecemos a la decana el apoyo que nos ha dado a ambas instituciones para desarrollar estas propuestas. Welcome to the third plenary session hosted by the School of Dental Medicine and the School of Nursing. Our guest speaker this morning is Dr. Stephanie Russell, and she will be talking about motherhood. Is motherhood bad for oral health? Actually, parity and oral health, pregnancy, and scientific evidence, potential mechanisms and implications for practice and policy. This is the second time we have invited this semester Dr. Russell due to the importance of her presentations, and we appreciate that you have visited us twice. A little bit about Dr. Russell. She has a PhD in epidemiology from Yale University and various professional certificates in general dentistry, periodontology, so she's a dentist and a periodontist, and geriatrics. She is currently a professor at the Epidemiology and Health Promotion Department in New York University College of Dentistry. Dr. Russell has also been awarded with Student Council Appreciation Award, so she's been involved in teaching as well, postdoctoral fellowship, Paul Ambrose Scholarship Award to mentor dental students, and a loan repayment program. Her primary areas of interest are the oral health of women and the elderly, and the relationship between systemic and oral health as well, including HIV infection and pneumonia. In addition, her areas of research, of course, include social determinants of health, of oral health, and predictors of research participation among minorities. That some of these projects have been conducted in collaboration with dental school, with our School of Dental Medicine. Dr. Russell serves as co-investigator, research mentor, associate director, faculty advisor, but most importantly for us, she's principal investigator of NIH-funded grants. Stephanie, please.
Thank you so much, Dr. Ilias, for having me. I'm so happy to be here at UPR to talk about what I think is my favorite topic, and that's, is motherhood bad for oral health? This is something that I've been looking at for about the last 7 or 8 years, and I'm going to talk about historically where this line of research has come from. I'm going to give some of the literature review background to different studies that have been done. I'm going to talk about some of the research that I've done, and then where we go from that in terms of trying to affect the social determinants of health in order to improve oral health. Gain a child, lose a tooth is a very common kind of old wives' saying in English that means that for every child that you have, a woman will lose a tooth. And this also goes across cultures. So it's found in Denmark and Europe, and it's found in South America. And it's something that I first saw when I was a research assistant, actually about 10 or 12 years ago. We did focus groups on a different topic of HIV-related access to care issues for HIV-positive women and their children. And we had some focus groups of African American and Hispanic women, and we found that this topic kept coming up, that, you know, dental health is adversely affected by pregnancy, and that if I'm pregnant, I'm just inevitably going to lose teeth. You can just Google this saying, and you can find many discussions on the internet about this. Here are two quotes from different websites. The first one says, "My teeth and I have formed a relationship during my pregnancies, and it's simple. I have a baby and my teeth give two to the cause. So basically I lose 2 teeth every time I have a baby. It's not a nice part of pregnancy, and it's also not an openly discussed part. Let's face it, who really wants to admit that their teeth rot and decay during pregnancy?" Another quote was, "Pregnancy is hard on my teeth. I only had 1 cavity until after I started having children, and now I probably have a dozen or more fillings." So women actually believe that tooth loss, caries, is common in pregnancy and is related to pregnancy, and that basically their dental health will deteriorate with pregnancy. I went back we have a great dental library at NYU, which has a lot of old journals and textbooks, and I went back to try to find, the first instance of when this might have been mentioned in the dental literature, and I found back in 1885 an article that said, "It has long been recognized that pregnancy diminishes the density of the teeth. If these pregnancies are repeated, we see a series of disturbances occur, of which dental caries is the most marked." So we also see this coming from dentists and from researchers from way, way back. But I had 2 broad questions then, thinking about this perception in both the professional literature and among the lay public. And one was, is there scientific evidence actually to support this old wives' tale? And if so, how would bearing children have an effect on dental health? So the first thing that I did was a literature, and I tried to do a systematic and comprehensive search of some different databases that we commonly use, Medline, PubMed, Embase, and I searched terms like Parity, Motherhood, Mothers, childbearing, pregnancy, and oral health, oral hygiene, dental caries. I was trying to cast a very broad net, trying to look at studies that might have even looked at some other outcomes, but might have included data on parity and oral health. So I was looking at periodontal diseases, gingivitis, including gingivitis, tooth loss, caries, edentalism, and I limited it to articles that were written since 1970. I looked at all abstracts of the English language articles, and also I looked at some of the European articles for inclusion of the independent variable, the predictor, being number of children or number of pregnancies, and a dependent variable indicative of any kind of oral disease, including caries and various markers of periodontal disease and or tooth loss. So what I found was, I found 12 studies which identify either number of children or parity, pregnancy as an exposure variable, and had as an outcome oral disease variables, either caries, periodontal disease, and or tooth loss. Some articles looked at both tooth loss and periodontal disease, some looked at caries and periodontal disease. So for tooth loss, I found 7 studies, periodontal disease, 8 studies, and I put 9 in parentheses because I do have one study on periodontal disease that we did, but it hasn't yet been published, and caries were only 4 studies that I found. So looking at the parity tooth loss relationship, we see actually a pretty consistent relationship across the 7 studies that we've looked at, is that there actually is a finding that parity is related to tooth loss. There's just one study done in Africa with a very different population that was negative, but all the studies looking at parity and tooth loss are very consistent. This is one of the first articles that I found that really piqued my interest. This was an article published in The Lancet in 1987, and what they did here was this was a secondary analysis of a large database in Denmark, and this database comprised twins born in Denmark, and I think in 1980 something they were 70 years old, so they had been followed forward in time. And they had data on the number of children that the men and women had had. They also had a self-reported tooth count. So they asked the people to actually count the number of teeth in their mouths. They had social status data also. And what the investigators found, and here's just a close-up, was that for women, regardless of socioeconomic status, which, you can think in Denmark, well, there's not a big difference in Denmark between, high socioeconomic status and low socioeconomic status as there is here in the U.S. They found that number of children and number of teeth were inversely correlated. So the higher the parity, the fewer the teeth by self-reported tooth count. And they found this relationship both in men and women, but for women it was stronger. And it was stronger actually for those women of lower socioeconomic status. Here's a more recent study that was done in Germany looking at edentalism or tooth loss in men versus women. And this included also a large database where they had actually done periodontal exams, and the dentist had actually counted the number of teeth. And again, for women, in particular those of low socioeconomic status, the number of children and number of teeth are inversely correlated. They did not find this relationship in men. Looking at the parity periodontal disease relationship, we found 9 studies, well 8 studies in the literature and 1 study that we have yet to publish, and the relationship here is a little more not so clear. There have been several studies that have been negative and several studies that have been positive. And the reason for this is probably the methodology of the different studies, so that there's kind of a lack of consistency here of how periodontal disease was measured and who was included in the study. So that some of the better done studies actually do show a relationship between parity and periodontal disease. And this wouldn't surprise a lot of practitioners because we know that there's biological changes that occur with the periodontium when women are pregnant. So that, for example, if a woman has gingivitis when she's pregnant, and most women do, anywhere from 30 to 100%, if she has repeated pregnancies and she has underlying periodontal disease or risk for periodontal disease, does the repeated pregnancy gingivitis then have a long-lasting effect? And that's kind of the potential mechanism by which the biology could affect the relationship here. So here's just a few examples. There is a small study done, I think it was out in California, where they did standardized radiographs, and they looked at the cemento-enamel junction, which is a level on the tooth by which you can measure the degree of bone resorption on an X-ray, which is a sign of periodontal health, of periodontal disease. And what they found was, even that controlling for smoking and age, they found that alveolar bone loss increased with increased parity, so that there was a positive relationship between number of children and evidence of periodontal disease. Again, that study in Germany also looked at periodontal parameters, and they did an exam, and they found that gingival bleeding on probing was positively correlated with number of children. And they concluded that pregnancy-associated gingivitis seems to have some impact on long-term dental health, even though this gingivitis is considered a temporary disturbance. Looking at the parity-Caries relationship, there's only, I could only find 4 studies in the English literature, and only one study, the study that we did, was positive. The relationship between parity and caries is interesting, though, because a lot of women assume that when they're pregnant, that the pregnancy has an adverse effect on the hard tissues of the mouth, not the periodontium. They know that they have somewhere bleeding, but that they feel like, well, that kind of is normal, but that they really have an effect on the teeth, that the pregnancy causes calcium to actually leach out of the teeth, which we know is completely untrue. But I'm just going to give you a couple of the studies here that have been done on caries. One was a large study in South Africa where they looked at women who had small families, 1 to 3 children, and compared these these data to women with larger families, 5 or more children, and they found no relationship between caries and family size. Another study did exams of Hungarian women soon after delivery, and they also found, when adjusting for age, no relationship between caries and number of pregnancies. So, our conclusions from this review were that there's some evidence that the more children a woman has, the worse off is her oral health. Relationships between parity, number of children, and tooth loss are remarkably consistent. But those found for the antecedent diseases, those diseases that would cause somebody to lose teeth, caries and periodontal disease, are less so. Effects are likely, though, to be clinically significant. So when you look at the degree of tooth loss, it really is 1 to 2 teeth per child that were lost in the populations that were studied. And so we figured that this is really actually a clinically significant amount of tooth loss, and that these effects actually occur either independent of or related to common factors such as socioeconomic status. And the big question is why? Why is this relationship found, tooth loss and parity, periodontal disease and parity, maybe caries and parity? So I had to think a little bit about what were the study limitations. One was generalizability. Now, when we had the parity tooth loss, across all these different populations, it was remarkably similar. But then when we get into the other studies, there were such different populations, it was difficult to generalize some of these populations, for example, to people in the U.S., and very few of the studies had actually been done in the U.S. There were also questions regarding the reliability and validity of some of the measures that they used, for example, self-reported number of teeth. There were some possible sources of confounding factors in many of the studies that were not accounted for, including socioeconomic status factors, dental history, access to care, diet, smoking. These are major factors that can affect oral health, periodontal disease, tooth loss, and yet were not measured in many of the studies. And in fact, in most of the studies, there was really no investigation into reasons for the relationships found. Is it biology, or is it social determinants of health? So what we chose to do was to take a large database from the U.S., a nationally representative sample from the NHANES 3. We wanted to investigate the relationship between parity and dental disease in American women, and we wanted to look at specifically tooth loss, periodontal disease, and caries, because we thought we could maybe perhaps tease the relationship out between the antecedent diseases and ultimately tooth loss. We decided to use this to test a theoretical model that specified that parity, number of children, affects dental health both directly, for example, biologically, through repeated episodes of gingivitis, for example, worsening periodontal disease, and via mediators of social determinants that have been shown to be important predictors of dental disease, for example, access to dental care or dental utilization. This is where we started with our theoretical model. Back in 1993, Nancy Adler published an article in JAMA which specified that socioeconomic status can affect general health through 3 pathways, socially determined pathways. The first one was medical care, the one at the top. So medical care includes things like going for preventive visits, having access to care, having insurance. Second, psychosocial factors, degree of stress, also protective factors, for example, number of social contacts, those kind of things. And then the third one was health behaviors, so health damaging behaviors such as smoking, a bad diet, exercise. So what I did was I adapted this model to think about how socioeconomic status and parity might affect dental health. So I changed the medical care to dental care, psychosocial factors remained the same, and health damaging behaviors became those factors that are related, those behaviors that are related to poor dental health. We put parity in the model and saw that obviously it's related to socioeconomic status in general. Persons of lower socioeconomic status have higher parity. We also thought parity would be directly related to dental health, for example, through biology. And then we specified that parity would be related to all three things that are the mediators: dental care, psychosocial factors, and dental health damaging behaviors. So for example, if somebody had increased parity, they might have increased stress, which might affect their dental health adversely. Another example might be parity might affect diet of the mother, and that actually might be a positive relationship, so that if a woman has children and she's choosing to feed her children healthy food, then maybe she's going to eat more healthy too, and that might affect her dental health. Okay, so what we did was we looked at the NHANES 3 data set, which many of you I know has really excellent dental data in it, and it also has and the dental exams were actually done on these women. Very careful caries exams, periodontal exams, tooth count, and a lot of other factors was in this database. So I thought that perhaps we could tease out some reason that parity was related to these outcomes if we found such a relationship. We included 2,635 black and white women who were between the ages of 18 and 64, reported at least one pregnancy because we wanted to see the relationship of the number of pregnancies, had received a dental examination, retained at least one natural tooth, and had complete socioeconomic status, parity, and dental data. These are all the variables that we included in the model, and you can see that the NHANES actually has a lot of these variables. But the problem, and as I'll point out later, is that some of these variables are maybe not the best measures to include in these constructs. So that we had dental care, we had frequency of dental care, how often do you go to the dentist? Now, there's kind of a problem with that, because are we talking about preventive care, or are we talking about, episodic care where you need care to treat disease? Having current dental insurance. Socioeconomic status were measured by education, income, and an occupation scale. Psychosocial factors, we had a measure of psychosocial stress, marital status, and social support. Smoking, we included two measures. One was an objective measure of serum cotinine, and one was self-reported smoking history. Dental health damaging behaviors included cariogenic diet and the smoking variable. And then for our outcome variables, we had periodontal disease measured in a bunch of different ways, the best of which is clinical attachment loss, where we're measuring clinically the degree of separation between the epithelium around the tooth and the tooth. And I looked at separately treated coronal caries and untreated coronal caries, because I thought that there might be an interesting relationship there. So our statistical methodology included some standard descriptive methods. We did have some missing data, which we imputed in a program called PRELIS, and we used data for our analyses. We did have summated scales for social class, smoking, periodontal disease, and we created these in order to get rid of collinearity in the modeling procedure. We used path analysis to explore this model, and path analysis is basically a series of regressions that you can do to kind of figure out your model and figure out mediators or directionality of the way that the model goes. And we used what was called robust regression, because robust regression was better for data that had a lot of outliers in it. It was less sensitive to the outliers. So here we have some of the descriptive characteristics of the study sample, and this just shows you that number of births was related to a number of things in our sample. All the socioeconomic characteristics, education, PIR is poverty income ratio, is a standardized measure of income. SEI was our Duncan socioeconomic index. It was an occupational scale. And all these three things were, very, very highly correlated with parity. Only frequency of dental care, not dental insurance, was correlated. And in our psychosocial group, only being married was correlated with parity. None of our health behaviors or dental health damaging behaviors were related. Well, actually, smoking was, and the smoking variable was, but diet was not. Of course, age and race and diabetes were highly correlated with parity. These are all independent of each other, not controlling for any other factors. So what did we find just looking at parity and number of teeth? So dividing the sample up by age, we can see a very clear relationship between number of births and loss of teeth. So on the x-axis in the left-handed chart, we have 0, 1, 2, 3, 4 number of births. And on the y-axis, we have number of teeth lost. So you can see that for people who have had one child, for example, there's a relationship between age, and there's also a relationship between going up the group between having lost more teeth and having had more children. The right side shows that the same kind of relationship, but looking at the different socioeconomic status indicators, so that you can see that there's a clear gradient again between parity and loss of teeth, and this is true across all the socioeconomic status indicators, lowest to highest. Looking at the periodontal disease measures by parity level, again, we see a not so clear relationship with one of the measures, which is periodontal pocket depth, one way to measure periodontal disease. Another, probably better way to measure it is clinical attachment level or clinical attachment loss. And there you can see a relationship. This is not controlled for any other factors, but you can see that when you get up in the higher parity, 4 to 6, 7 plus, that we have a big increase in the number, the amount of clinical attachment loss present. When we look at dental caries, we found a very interesting relationship. We had two measures. One was the percent of surfaces that had been filled, and one was the percentage of surfaces that were decayed. And we don't see a very clear relationship in either total decayed and filled surfaces when you add these two together, or a clear relationship in the number of filled surfaces. But we do see that with increased parity, we had an increased number of decayed surfaces. So something is going on with higher parity and untreated caries. When we looked at the relationship, we tried to do our model, and this model I show for tooth loss, but it was very similar for for caries and for periodontal disease too. We could see relationships between socioeconomic status and our mediator variables, dental insurance, dental frequency, and smoking specifically. But we could not find that parity was mediated, the relationship between parity and dental outcome was mediated by any of these factors. So we were still at a loss for what we found this relationship, what might be the reason. Our conclusions was that parity was strongly related to tooth loss, and I think that the relationship, the strength of the relationship was roughly equivalent to the relationship between smoking and tooth loss, which is a very strong relationship. It was also related to periodontal disease and untreated coronal caries in black and white adult U.S. women, and this was when adjusting for potential confounders. So when we go back to that model, there was a relationship between parity and dental health, but it wasn't explained by any of these things, but it adjusted for all those things in the model. We thought that it was likely that among women, some disparities in dental health might be partly due to differences in parity and the physiologic and societal changes that accompany motherhood. But we were still unclear as to what the mechanisms by which parity affects dental health. And we've really felt that we needed further investigation to better understand the effect of parity on dental disease. And I think that the main reason that we, were unable to tease out this relationship was because some of the measures that we had were not really great for measuring the things that we really wanted to. We were stuck with the data that we had, and we were limited by that. So going back, why is this the case? Again, thinking about the mechanisms, we do know that there are oral manifestations of pregnancy. This is an example of pregnancy gingivitis, which, as I mentioned, according to different studies, occurs between 30 and 100% of pregnant women. There's increased bleeding, which increases as the pregnancy progresses. It's a hyperreactive response to dental plaque related to the changes in hormones in pregnancy, and usually when the pregnancy is over, this spontaneously goes away. Well, the question is, if this is occurring on top of pre-existing periodontal disease, can it make the periodontal disease worse? And indeed, some of the studies, especially some of the studies that have looked at preterm birth and periodontal disease, have found that some women actually periodontal disease does progress during their pregnancy. So in terms of the biology, we know that hormonal alterations associated with pregnancy affect the oral cavity. There are some other oral changes that have been documented. There's salivary changes, changes in the pH, xerostomia or excessive salivation, which can affect the oral tissues, hard and soft. There are changes in the oral flora, perhaps to a more pathogenic oral flora. And there are some immunological changes, and there are changes in things like whether or not there's increased vascularity, for example. But what I'd like to focus in on in terms of figuring out the puzzle is not the biological changes, which are pretty well documented, but the social determinants that are related to having children, and how these might be related, or how these might explain the relationship between parity and oral health. So we know that there are many issues related to socioeconomic status and gender. For example, child care issues, psychological stress, marital status, social support, which could be positive or negative related to pregnancy and motherhood. We know that there are changes in behavior among women that are associated with pregnancy and motherhood. So we know that dental care utilization is very much related to pregnancy, so that pregnant women are much less likely to visit the dentist compared to non-pregnant women. And we know that there might be changes in health protecting or health damaging behaviors. For example, during pregnancy, many women who were smokers give up smoking, and some of them stay non-smokers after pregnancy. We also know that this is affected probably by women's attitudes towards dental treatment when pregnant, so that some women are fearful of going to the dentist when pregnant, or some women feel that, well, I'm having more dental disease, I need to go to the dentist more when I'm pregnant. And then there's also dentist attitudes towards treating pregnant women. And I know that a lot of these attitudes persist despite a lot of studies showing the contrary, that performing most dental procedures during pregnancy is safe and beneficial to the mother and probably the child, but that there is still a fear among dentists about things like litigation if something were to go wrong with the pregnancy. So let me just review some of the studies that have been done which provide support or negate some of these relationships. It's been shown over and over again that pregnant women tend to see the dentist very infrequently. One study in North Dakota found that only 43.2% of women had actually gone to the dentist during pregnancy. The CDC collects data on pregnant women's behaviors by state, and this pregnancy risk assessment monitoring system, the PRAMS data, show that between only 23 to 35% had gone to the dentist during pregnancy. And quite strikingly, those who reported a dental problem saying, I had a dental problem while I was pregnant, only about half of them actually went to the dentist, which is kind of alarming. Looking at insurance claims data, it seemed that women tended to go to the dentist much more before pregnancy and after pregnancy, but not during pregnancy. So there was a dip while women were pregnant that they tended not to go. I looked at this in New York State because I was really interested in what was happening in New York over time. And you can see I looked at data from 2004 to 2008. These are different, the different bars. And I looked at white, black, and Hispanic women in New York State. And I found that, it was strikingly similar to the data that had been presented before in terms of the proportion of women who actually go to the dentist. And this was women who reported a cleaning. So this was women who were going in for preventive care during pregnancy. And it was pretty low, totaling around 40-something% of all women, and that there were differences in racial ethnic composition here, so that African American black women were much less likely to go to the dentist compared to whites and Hispanics. And over time in New York State, it doesn't seem like a lot has changed for whites and blacks, but it does seem that there might be a trend among Hispanic women to go to the dentist more often for a cleaning, which I found to be interesting and encouraging. Looking at education, there's a clear education gradient here, not big difference by year, but those women with more education were much more likely to have a dental cleaning when pregnant. Looking at Medicaid status, now in New York State, Medicaid is actually very generous for dental treatment and pays for a lot of dental treatment, and it's even more generous, as it is in many states, when women are pregnant. So that there are a lot of women that don't have insurance before they're pregnant, but they get on Medicaid when they're pregnant, and that kind of opens the door possibly for them receiving dental care. And then after they give birth, then they are no longer eligible for Medicaid. So this is an important relationship, and I was struck that those women without Medicaid, those women with Medicaid who actually had insurance for dental care when they were pregnant were less likely than those with no Medicaid, many of whom did not have any insurance to have a dental cleaning during pregnancy. Some studies have been published that look at reasons that women avoid going to the dentist while pregnant. One study in rural Oregon interviewed women in focus groups and found that the stress associated with pregnancy, also dental barriers, not being able to find a dentist who takes Medicaid, that kind of thing, who treats pregnant women, were definite barriers. Looking at Medicaid eligible women in Washington State, found that satisfaction with dental care among this population was low, and I think a lot of studies have found this independent of pregnancy. The majority agreed with the statement that dentists and also staff are sometimes act rude to their patients. There are reasons that dentists actually avoid treating pregnant women. They're oftentimes reluctant. This is a quote from one of the studies, one of the focus groups. I tried to get my teeth done during pregnancy, but the dentist wanted me to sign this waiver that if anything happens to my baby during my delivery, that he wouldn't be responsible, and I wasn't comfortable with that because he really freaked me out. When dentists actually do see pregnant women for treatment plans are usually altered or delayed because of the pregnancy. So many times the dentist will say, well, you're pregnant, let's wait until after the pregnancy to fix this tooth, to extract this tooth, to do a cleaning. And this is, whether or not this is well-founded, this is something that's been taught in dental schools forever and is still being taught in dental schools, that really the safest time to treat a woman is during the second trimester. Well, this is fine if you have a woman who has regular dental care, who, can come in during the second trimester. But a lot of the low-income women, when they come in, it might be more prudent to treat them, whether or not it's the first, second, or third trimester. And I'll talk about the safety of this in a minute, because you never know when you're going to be able to get them back in the chair again. But these are two recent textbooks which, still teach that it's really possibly unsafe to treat a woman during pregnancy. Although the correlation between routine dental care and fetal injury during the first trimester is unknown, it's prudent to limit care to emergency care only. This kind of goes against a lot of the studies that have looked at preterm birth and oral health, periodontal disease, and that, some of the reasons that people think that perhaps these studies have not found that providing treatment to women during pregnancy have been negative. the reason is that we're not treating the periodontal disease early enough. So it's kind of an interesting problem there. Another quote from a recent textbook: other than as part of a good plaque control program, elective dental care is best avoided during the first trimester because of the potential vulnerability of the fetus. And then, this kind of scares dentists into thinking, well, maybe I should just defer all treatment until the woman is no longer pregnant. So traditionally, it's been advised that routine care, including dental cleanings, should be provided only during the second trimester, and that care not be provided late in the third trimester. Advice, though, is not consistent, and there are no national guidelines for providing care during pregnancy. Dentists tend to be cautious people, and they tend to err on the side of caution. Dentists also might lack confidence in their ability to safely treat pregnant women, not really knowing, can I do this, during the different trimesters. They might be unsure, for example, whether it's safe to take radiographs, administer anesthetics, prescribe medications. Obstetricians, though, when they've done studies comparing dentists and obstetricians' views on dental treatment during pregnancy, believe that dentists are actually overly cautious about providing dental care to pregnant women. This is a letter, which I'll highlight a quote from it in a minute. This is a letter that was sent from a physician in New York State to the state dental director, Dr. J. Kumar, which explained what happened to one of his patients. He was treating a patient, and she had some dental pain. He said because the pain was so great, she took excessive doses of Tylenol, resulting in toxicity to her and her baby. This was dental pain. At the time, she was approximately 29 weeks pregnant. The baby died from liver toxicity. My patient suffered acute liver failure and was flown to Pittsburgh expecting a liver transplant. So, Dr. Kumar said, well, this is kind of crazy, that a pregnant woman in pain, even in pain, cannot find a dentist to treat her. And New York State, as a result of this happening, came up with a set of guidelines. They convened a panel of experts, including obstetricians, dentists, various medical people, researchers, to come together and review the literature and come up with a consensus and some guidelines of how to safely and properly treat pregnant women, provide dental care for pregnant women. These were published in 2006, and they're on the internet, and it's a large document, very detailed about reviewing the literature. But the most important message here was that dental care is safe and effective during pregnancy, and that needed dental care, so restorations, control of gingival inflammation, can be provided throughout a woman's pregnancy. Importantly, a delay in receiving necessary dental care could actually result in significant risk to the mother and the fetus, so that it's actually dangerous not to provide the proper dental care while pregnant. And just going back to these studies that show that have been investigating for many years now, almost 20 years now, the relationship between having periodontal disease and having an adverse birth outcome. Now, while all of the studies, prospective, retrospective, case control, all those, many of those studies have found a relationship between poor periodontal health and poor birth outcome, including preterm birth and low birth weight. When they went ahead and tried to provide dental care, cleanings, deep cleanings for women who had periodontal disease while they were pregnant, they found that in these randomized clinical trials that there was no benefit to providing actually this treatment. And people were kind of puzzled because the relationship seemed to be so strong in the other studies. But again, people have thought, well, perhaps you need to treat the woman before she actually gets pregnant or very early in the trimester, the first trimester, for the treatment to have any effect. Or maybe we need women that have much more disease than we were including in these studies. There is really a rationale for providing dental care for pregnancy, and I would argue that, for one thing, it improves the oral health of the mother. That women, obviously have disease while they're pregnant, and this could really help set them on the right course because they're seeing a dentist while they're pregnant. Prevention of poor pregnancy outcomes, perhaps the jury is still out on that. one very important thing is that it's been shown by providing education to a woman while she's pregnant about the subsequent risk of oral disease in her child, that you can actually prevent future oral disease in children by counseling pregnant women. And this is pretty strong, a strong relationship, and is consistently found in studies. And what we're talking about here is mostly early childhood caries, which we know is still a huge problem in this country, and I know a huge problem in Puerto Rico. We know that early childhood caries, despite being such a horrible thing, is actually preventable with the proper education and instruction. We can actually, this disease does not have to be. We know that caries causing bacteria, strep mutans, are transmitted from the mother to the child at a certain time point. We know that mother's caries levels is actually very predictive of the future level of caries in the children. And most importantly, perhaps, studies have shown that intervention during the perinatal period, pregnancy and early childhood of the mother has been shown to both reduce strep mutans levels in both the mother and child, and has been shown to decrease caries in children up to 14 years of follow-up. This is very strong evidence that this is something that really we should be doing. There are also some reasons why you would want to provide dental care during pregnancy. One is that pregnancy obviously affects oral health biologically. Another is that many women are covered for dental care, for cleanings, for example, in New York State, only when they are pregnant. So getting them in while they're pregnant can really affect their oral health positively and the future oral health of both them and their children. Another important thing is that pregnancy is really sometimes seen as a window of opportunity, a time when women tend to take care of themselves, and this is kind of a teachable moment so that women are maybe more open to health messages, they have greater contact with the health system, and it's just a really good time for prevention, for talking about medical problems, dental problems, and women tend to be very receptive because they are worried about their health and they're worried about the health of their future children. There are some gaps, though, between practice and research. Again, we have guidelines now not only from New York State, but from the California Dental Association, from the American Academy of Pediatric Dentistry, and a couple of other organizations which really try to get the message out that treating pregnant women is safe, effective, and that women who are having dental problems, especially during pregnancy, should be seen. But there are still barriers to getting dental care or providing care that are likely to vary by the situation of the woman. For example, cultural attitudes towards having dental care when pregnant, or socioeconomic status. And the practitioner, for example, knowledge and education of the practitioner, what the practitioner might have been taught in dental school. And studies with adequate data on subpopulations are actually scarce. So many studies in the U.S. have looked at, white rural women or white women and have not really included adequate groups of Latinas or African American women to see how the attitudes among these groups might differ and might prevent them from seeking dental care. In addition, there are, because of these guidelines, there are some programs that have been established to try to get pregnant women into the dentist, to see the dentist. But there's really nothing known about what makes such a program successful or unsuccessful. There are no published studies of the effectiveness of interventions designed to increase dental attendance and promote dental care or dental health among pregnant women. So from the research that we did on Parity, it was natural to try to find such a program and to see how a program like this might work. And I was very lucky to meet a dentist, a private practice dentist who was a periodontist with a master's in public health, who was very interested in the oral health pregnancy relationship. And he has a private practice out on Long Island, in kind of a wealthy suburb of Long Island. But he's on staff at a public hospital where they have a large Medicaid prenatal clinic. He, after the guidelines were published, he teamed up with the obstetrician and with the nurses at there were two clinics, two Medicaid prenatal clinics, and he teamed up with them to devise a system by which these women could actually get dental care. And since 2008, when this program started, he's seen actually in his office with his hygienist and his staff over 1,200 women for diagnosis, prophylaxis, and scaling and root planing, which is a treatment for periodontal disease when this is indicated. And they provide the treatment regardless of what trimester it is. Pregnant women are asked, as stated in the guidelines, it's a good idea to ask pregnant women, well, when was the last time you saw a dentist? And those who report last seeing a dentist as over 6 months ago are referred for dental treatment. There's a form that is available in the New York State guidelines that can be used by an obstetrician, filled out for a woman, and then given to the dentist, which is basically like a medical consult form that we would use for any medical issue. And it's basically, you know, a recommendation form or a medical clearance form that says that it's safe to perform the following procedures for this woman. And it talks about whether, you know, the doctor can make notes about whether it's a high-risk pregnancy or what the problems are, whether the woman has diabetes, for example, and might be more at risk for periodontal disease, what procedures might be contraindicated to the specific woman. And this form, you know, can easily be used. They decided to use this form and would fill it out for each woman. The nurse would fill it out and then actually fax it to the periodontist's office. What we wanted to do then was, this program had never really been evaluated. Even though we knew that they had seen a lot of women, we didn't really know about the success of the program. You know, how many, okay, so 1,200 women were seen, you know, were 10,000 women referred? You know, we didn't really know. But we wanted to find out kind of what proportion of women are being referred to a dentist in the clinics, and then of those, how many actually go? So we started to analyze this program by first doing a survey of the clinic patients in the perinatal clinic. And we approached almost 370 women over a few-week period in the summer. We collected data from almost 300 women, about 80% of women. We gave them a $5 gift card for a meal in the hospital, so that women were very happy to do the survey. We found a very heterogeneous population, about a third black, about a little more than a third Hispanic, and only 10% white. And actually almost half of this population was actually born outside of the U.S. It was not a wealthy population. It was a Medicaid clinic. About a quarter reported household incomes of less than $10,000, and another third between $10,000 and $20,000 a year. But what we found was really interesting. We found that 3/4 almost reported that they had actually been referred by their prenatal clinic for dental care, which is pretty astounding, because I think that, you know, this is unusual for a prenatal clinic to do. And of these women, 63% actually reported that they had actually gone to the dentist. Not necessarily the periodontist where they were referred, but maybe to their own dentist or another dentist in the hospital, for example. Of those who were not referred, though, only about a third had seen the dentist. So this was a huge difference between those who'd been referred and those who had not been referred in the proportion of women who had actually seen a dentist. And we didn't exclude women based on, you know, how pregnant they were. So this was a big group of, you know, some women had just gotten pregnant, some women were in the third trimester. Of those who reported having dental care, having gone to the dentist, a full 3/4 reported that they had gone because their prenatal clinic had referred them and told them about the importance of going. So, you know, I thought this was pretty astounding so far, that these results demonstrated that a referral program for low-income pregnant women attending a Medicaid prenatal clinic is likely to be successful in promoting access in a group with traditionally low rates of dental care utilization. And I think that improving the oral health of pregnant women may ultimately reduce disparities in oral health by improving the oral health of these women, of their children, and of their families. Implications for dental practice. I think the practice should really follow the guidelines from either New York State, California, and hopefully one group will come out, perhaps the ADA, with national guidelines that are changed from the old guidelines. Women should actually receive education, exams, and necessary care during pregnancy, being mindful, of course, of safety issues and taking advantage of this teachable moment or window of opportunity. Dissemination of current guidelines, though, should be improved because I think a lot of people, practitioners, academics, researchers, don't even know that the guidelines exist and that the guidelines have kind of changed since maybe they were in dental school. And education of dentists and dental students is very important and should take into account the recognized safety and effectiveness of dental care during pregnancy. I'd like to thank the organizing committee of the Research and Education Forum, Dr. Elias, for inviting me here to talk about, what I think is my favorite topic. Dr. Kumar and the New York State Board of Education for creating those guidelines and providing that slide with the letter on it, and Dr. Rabin, who is the obstetrician, and Dr. Steve Kirpin, who is the periodontist at Long Island Jewish and North Shore Hospitals, for providing me with a forum to analyze the success of their program. And I really thank you for your attention and interest. I'd be happy to take any questions, and also by email, be happy to answer any questions. Thank you.
Tenemos unos minutos para preguntas, así que, doctor, yes. Y que por favor pasen a los micrófonos para que se oigan.
I have several questions, but I'll talk with you later. Is it too early to measure success in this clinic? Have they looked at, for instance, tooth loss and periodontal disease and this type of thing?
The other thing that we did that I didn't show is that we went in and we reviewed the charts of the women from the clinics who were referred to the periodontist. So we went in, they provided us with their charts, and we're analyzing that data now. So we do have information on dental status. It's kind of rough. We have information on whether or not they received scaling and root planing, so that's our measure of whether or not they have periodontal disease. And we also have tooth loss measures, as well as some socioeconomic status measures. This is, of course, a different sample than the one that we got from the clinic because these are women that actually received treatment. So we'll be analyzing that data. So, yeah, I have that data, but I haven't looked at it yet.
Okay, and maybe the scientific ones. Have you looked at the vitamin D status of these patients?
Yeah, that would be an interesting thing to look at. We're not, our next step is perhaps to go in and look at the medical charts and look at some medical indicators because we are still interested in looking at measures of preterm birth, for example, that things that might have precipitated some portion of the population experiencing that. So, our next step is possibly to go in and look at some of the medical charts and lab values of these patients.
Okay, and the third, the teeth are sometimes a reflection of what's happening in the rest of the body. So, for instance, could this be used as maybe a predictor of maybe osteoporosis or the correlation between the tooth loss and osteoporosis? A lot of people don't get measured for the bone density, and it might be an easier way to be able to maybe indicate that these persons may be at higher risk.
Sure. I guess you'd have to follow the women for a long time, though, after the pregnancy, because a lot of these women are pretty young. The mean age was like 25, and I don't think we'd possibly find big differences in bone density. But yeah, possibly. Yeah, we should definitely include. We could include, for example, family history of osteoporosis or the risk factors for osteoporosis in our analysis, which would be interesting. Thank you.
Anybody else would like to comment? I have something to share with you. I noticed that on the decay index versus the field index, there were some association differences. We had that same problem when we studied lead levels and dental caries. And actually, with the DMFS by surface, we did not find any association. However, by using the DMFT, we did find some association. And we have attributed this to the fact that when you prepare teeth, you have to, for access, you have to, destroy or prepare some surfaces that are not, have not been decayed, so that might be confounding the association. So maybe the DMFT would be a better analysis. Follow me?
We looked at
At
DNS.
TNS.
We looked at TNS though. And there was,
Both of them.
they were consistent. They were consistent. Yeah, yeah. No, it was consistent. And I guess that we decided that probably the reason was is that those women that had very high parity, did not either have the time to go to the dentist, or else they went and they had a temporary restoration placed while pregnant, and then the restoration fell out, and that might be the reason for the increased untreated decay.
¿Alguien más que quiera contribuir? Le voy a pedir a la doctora Río que nos acompañe, a la doctora Regueira también de la Escuela de Enfermería, que encontramos muchas áreas en común aquí que podemos trabajar.
We wish to present this token of appreciation and a beautiful certificate for the outstanding contribution to our Research and Education Forum. And we hope that you can come back at another time to lecture not only at the level of the campus but also at the level of the school.
Thank you so much.
Of the School of Nursing and the School of Dental Medicine, we would like to thank you for your participation in this 32nd Annual Research and Education Forum.